to Professor Shukla. We'll be talking about, it's a burning topic, myopia and pre-myopia. And initially we were in myopia, now we are getting into pre-myopia because if we catch them young, so maybe myopia burden will be less. So that is the idea. That's why more and more stress on pre-myopia. So we all know that we came from ocean. So there was darkness and we could see only at near distances. We could not see very far because light was limited. So we were programmed for myopia, you can say, in that way. And as we became terrestrial, that had to change. Refractive index was also very little between air and cornea, between water and cornea. And once we came out between air and cornea, refractive index also increased. So the need for globe to get, for the axial length to decrease. So this has been a conflict and what we call as emetropization. So you may say that once we came from ocean, we were programmed for myopia and that got adapted later on. So as we know, myopia is the incidence and prevalence are rising exponentially. By 2050, is going to, half of the world population is projected to be myopic. Prevalence of high myopia is also likely to increase. And we are at the cusp of an epidemic, and we are all, especially in Southeast Asia, China and Hong Kong and those areas are having about 90% children are turning to be myope. So what is pre-myopia? A refractive index of plus 0.75 to minus 0.5 diopter is taken, that range is taken as pre-myopia, means that they are prone for getting into myopia. So this population needs to be looked after and looked after very carefully, that some of these may go for myopia. So if there are other quantifiable risk factors, provide sufficient likelihood for future development of myopia to merit intervention. So not all of these will require intervention. First we need to identify and then we need to see which one of these need to be interfered with. So it is important when and what to treat and how to treat and when to treat. Now identifying the pre-myopes. Family history is important. One myopic parent, the risk is threefold, and if both are myopic, the risk increases exponentially. Visual environment. Less outdoor activities, less than 90 minutes per day is a risk factor. And same way is the near work, which is if it is more than 3 hours per day out of school time. So these two factors are most important, the outdoor activities and near work. As I was saying initially that we came from ocean, so we are programmed accordingly. Binocular vision, things like high AC by ratio, accommodative lag and exotropia are also important to be looked into because a good number of exotropes are found to be myopes as they grow older. There is a hyperopic reserve. So a person with plus 0.75 diopter hyperop at the age of 6-7 is less likely to go into myopia as compared to a person who is having less hyperopia, and this in Asian children about plus 1.5 is taken as this hyperopic reserve. So we need to have more reserve as compared to Western population. Then if you are losing more than 0.5 diopter of hyperopia in 1 year, that is again a risk factor. So all these have to be taken into consideration. Now this refractive development and emetropization, I will not be talking in detail. We all know that emetropization is a slow process and goes on for a couple of years. By about 6 years of age, most of it has taken place. So all of us lose some hypermetropia. Most of us are born hypermetropes. Some are of course born as myopes as well. So some hypermetropia is lost. This is a very complex process. We don't understand everything. And you can say that there is a retinal defocus, both myopic and hyperopic eye growth is regulated. Identifying these components offers novel therapeutic modalities. Afferent arm is, as we'll see, in the peripheral retina, and efferent arm is poorly understood. Atropine affects eye growth through muscarinic and non-muscarinic effects. Dopamine has important role. As we know, dopamine, serotonin and melatonin, they are all related. And dopamine affects eye growth. There are D1 and D2 receptors in the retina, and a lot of atropine effect is because of working through dopamine. Now, approach to pre-myopia, what do we do? Preventive aspects, that will include outdoor activities, classroom lighting levels, less near work. Parental myopia is a risk factor, and things like AC by ratio, axial length and peripheral refractive refraction, they are poor markers for these children. Now, when do we intervene? How much outdoor time, we don't know. Whatever is known for myopia, we may not directly translate to pre-myopia, but whatever is applied to myopia, we may extend that, but about, say, how much near work, more than, as we said, more than 3 hours will be poor, and more than 13 hours of outdoor time will be risk factor. Low concentration of atropine has been tried in these cases. Myopia control spectacles have also been tried of late, both DIMS and other one, because earlier they were not good candidates for this therapy, but because they were not using glasses, but there have been studies which have shown good results. And RLR therapy has also been shown to be effective in these cases. Now, therapeutic options in pre-myopia include robust experimental and clinical evidence regarding effect of dopamine, epinephrine on axial length of the eye. Atropine 0.02 to 0.05% seems to hold promise. ATOM-3 study is underway to address role of weak atropine eye drops, 0.01 to 0.05% in pre-myopia. Devices employing myopia defocus in pre-myopia, both HAL and DIMS lenses have been tried. There are studies recently which have shown that this is effective, and RL therapy has also been expensive, but it has been used in China. Now, there are 4 studies which have shown use for atropine in the last 3-4 years for in pre-myopia. This is limited data. I think it will need to be improved with more studies. Now, atropine efficacy may vary with ethnicity, more efficacious in European children and less efficacious in our population. 0.025 may be the midway choice. Increasing outdoor time and atropine therapy may be combined, and it may work better. Now, the key interventions include increasing outdoor time to about 13 hours per week, and the effect is most powerful in children from 3 to 9 years. There is a 20-20-20 rule for near work, which should be adopted, low dose atropine, and follow up at 6 months. Now, indirect myopia, pre-myopia predictors could be high AC/by ratio, accommodative lag, and accommodative retention, and IXD. So, if these are there, they indicate that child may be moving on to myopia from pre-myopia. Now, the future questions: understanding and pigeonholing pre-myopia at clinical, cellular, and molecular level. What, when to treat, age, options, optimum dose, frequency and time of application, nightly, weekly, duration of treatment, up to what age, potential rebound phenomena, age at which therapy can be stopped, mode of action, and anti-muscarinic drugs. Thank you. So, it's a vast area and lot of things are happening, and I think with time we will learn better about it.